Welcome to the Hyper Guy Motivational Podcast. Thank you so much for joining us today. I am here with my wonderful co-host today, Paul Danchek, and he's going to take over from here.
Thanks, Martine. Super excited to have Richard Figueroa, the Deputy Cabinet Secretary for the California's Governor's Office. Richard, thanks for joining us.
My pleasure. Happy to be here.
So Martine and I were scheming behind the scenes. We'd like to get some insights to learn more about you and how your career has evolved over time, and then start geeking out on this leadership space within public service, and maybe get into some policy questions around the healthcare system within California. Sound like a good place to start?
Sure. Go for it.
Where you are now as a Deputy Cabinet Secretary isn't where your career started. Go way back. Tell me about your family life. Where'd you grow up? What was it like growing up?
Sure. So I grew up in Oakland. And for those of you that are familiar with Oakland, I grew up in East Oakland, kind of at the outer edges of the Fruitvale district, which is the traditional heart of the Latino community in Oakland. Oldest of 9 children. My mom was, for many years, a stay-at-home mom, as you might imagine, given the 9 kids. And a number of us were just like a year and a half apart. And then my dad was first in the Army. He was part of the U.S. occupation forces of Japan, and then fought in Korea during the Korean conflict, and then came back and became a steelworker. And so he worked at a place called American Can Company for, 40 years, 45 years. So it was a traditional kind of working class, but for them, pretty large family. I had a shirt that I was always kind of proud of growing up. It said Mexican, Catholic, Democrat, Raider fan. So that was that was kind of a lot of what we did. A lot of it was, around church, obviously rooting for our favorite, sports teams. I was always, some of it was obviously, part of our heritage and doing heritage-based activities. And then I was always personally interested in politics. My dad was a shop steward, and he used to, get involved in struggles for workers' rights, obviously as trying to be a leader in the union. And then as part of the union movement, would participate in kind of the large-scale political rallies that used to occur as well. So I was always had a little bit of an interest in that part of the world.
What was it like growing up with 8 siblings?
You always were rocking and rolling as the oldest, there's 7 boys and 2 girls, and I was the oldest. And so at a pretty young age, had to learn how to feed children and change diapers and do babysitting and, laundry and all kinds of stuff like that. So we were a pretty rambunctious crowd. When I went to college, some of the kids were either still in the process of being born or were still pretty young. So I saw some of the younger ones less than I did some of the older ones. But certainly it was a pretty, we had all of our socks were color coded, so we wouldn't, get them all mixed up. And it was a, pretty raucous bunch at the dinner table, as you might imagine, for those that weren't constantly in the high chair.
There's always someone in the hot seat.
there was somebody always in the high chair the entire time. Even when I went to college, the youngest was still in the high chair. So there was still lots of diapers around, even when I went to college, and high chairs and little baby spoons and little baby cups and stuff like that. So, but we got along. There's lots of game nights, and when you have that many children, you're less likely to go to big vacations that cost a lot of money. You kind of make your own fun. And so we did lots of, trips to the park and trips to the zoo, and just kind of a lot of times just kind of made our own fun. Obviously, it wasn't always fun for my parents, because with that many kids, there was always 1 or 2 or 3 agitating against another 1 or 2 or 3. That's just kind of normal sibling stuff.
What's the worst trouble you got into as a kid?
I don't really know. I think one night I went to a high school basketball game, and there was something, when I got home, my parents were busy doing something in the other room, And so I went to bed, and I didn't find out till like 1 or 2 in the morning that they had like called the school, called the police department, whatever. And I was asleep upstairs the whole time and never even knew any of that was going on. So I think I got in a bunch of trouble for that. But again, it wasn't like, I didn't do anything bad, but I didn't know that they didn't know I was home. And so that was kind of freaking them out quite a bit. So that's probably I probably got in a bit of trouble for that one.
Did it freak them out, or did it freak you out?
Well, it freaked them out first, and it freaked me out that they got freaked out. So, but yeah, that was I mean, like any urban area, when you're out, very late and you don't come home, and they can't. This is before the time of cell phones or anything like that. You worry a lot. So.
I can totally understand that. You gave this great visual of a T-shirt that you used to have that had Mexican, Catholic, Raiders,
Democrat, and Raider fan, and it was green. It was green. It had 4 boxes, and they're all checked because it was kind of that way, kind of in my neighborhood. It was very, the Latinos there were Catholic. They're all big families. Democrat, mostly blue collar union, and heavy Raider fans. We live kind of in the foothills right above the Oakland Coliseum. So from my back bedroom, we actually could see people walking into the 3rd deck. That's how close we were. And so when the Oakleys used to, we were A's fans too. And when they would, we knew when they were playing at home, because every time they hit a home run, there'd be fireworks. There were fireworks almost every night in our neighborhood. And, many happy memories around. It could have been the Warriors, it could have been the A's, it could have been the Raiders. We had a professional hockey team for a while. We had a soccer team called the Stompers. So we were always, we were close enough to walk to the Coliseum, although we wouldn't do that very often because some of the neighborhoods real around the corner were a little less safe than where we grew up. But a lot of our world also revolved around the Oakland Coliseum and all the various sporting events and things like that we were able to go to.
Was it the 9 of you?
Was that
11 of you that went? Who went to the games?
Well, my dad would take us, or I would go. I mean, there are probably always 3 or 4 of us that would go. I think most of us would go when they had the free giveaways. Whether there's 7 boys, and so they would have bat day, cap day, things like that. Some of the giveaway days we would tend to get more, but all the tickets were half off on Monday nights. And so we used to go sit in the bleachers, they're for like $1 or something like that. And we'd go with neighbors or things. Hey, who wants to go to the game? So we used to spend a lot of time at the ballpark. My sisters were interested too, but they were also younger. And so they may have gone more when I was like in college or a little later on and things like that. But it was the 3 oldest boys. My sister would go, the oldest girl, and then there was then there's 2 more boys. And so when I was there, when they were old enough, it was mostly the boys that went.
Did that carry across? I mean, your love for sports and watching sports, did that carry across to you playing?
Did it carry across to what? I'm sorry, Paul.
For you playing sports, did you play?
Oh no, I was never that good at sports. I was much more into books and newspaper and journalism and things like that. So my high school was very small. They also had a pretty limited number of sports, but for example, a guy named Dave Stewart, he was later a famous Oakland A's pitcher, was a year ahead of me in high school. Strangely enough, me and my brothers, we weren't very big. We were all pretty thin and smaller. And so I was actually the head of the chain gang at the football games. The down markers, marking marking where the ball was, between the 10-yard lines and things like that. So I contributed in my own way by being the head. And back then they were real chains between the 10-yard markers, real chains, and there was a thick chain, and you'd be very, very careful because the players would run off the field half the time. If you weren't careful, they ended up sprawled on the ground because they tripped over the chain. So back then it was like real chains and stuff back in the day, real cleats, real chalk. It was different time.
Do you have a favorite memory doing that job?
Just being when it rained, it was miserable. it was just miserable because you had to wear you didn't really get to like wear a poncho. You had to be seen and stuff like that. I just remember it was interesting because you were so close to the game all the time, but you were also just really busy. We had a little clip that used to put on exactly where the ball was as part of the chain when you measured, and we never put the ball down on the ground. It was always the referee, but you knew that your classmates were kind of glowering at you based on the spot of the ball, and if you didn't, if you pulled the chain too tight, oh my God, you missed it by a quarter inch or something. So that was always a little bit intimidating. But you were doing your job, whatever that was.
Recognize whenever you're in high school, your jobs can change pretty fast. How long did you do that job?
I want to say I did it 3 years. I might have done it all 4 years I was there.
What kept you doing it?
I mean, like I said, I wasn't very athletic, so it was my way to contribute. It's something fun to do on a Saturday afternoon. I enjoyed the atmosphere and the crowds, and again, you're around your classmates, although you had a little bit less of a traditional role.
Where'd you go after high school?
I went to UC Davis. I was very interested in weather and atmospheric science in high school, and went to UC Davis and was an atmospheric science major for maybe 2 years or so. I soon realized it was actually more like a physics major kind of thing, and I didn't enjoy it as much. At the same time, I was very active in like student activities, and student government and stuff like that. So I just started kind of slowly drifting away from atmospheric science and kind of end up going into sociology, sociology/social welfare. That ended up being my major at UC Davis.
I mean, you shared earlier how your dad was a shop steward and you used to go to rallies.
Oh, I was always interested in politics. Martin is probably not old enough, but even in like high school, I used to study all the propositions and ballot initiatives and things like that. And my parents just I was not old enough to vote, but my parents would on occasion ask me, "What do you think of this?" And I was pretty well studied and well read on those things. I was just naturally interested in politics and the working of politics and the kind of policies that the legislature or the people through the initiative process were putting forth. It was just a natural interest of mine for whatever reason.
Nice. So when you're in UC Davis, part of the Aggies, you went to student government then, or what other type of?
I did different things in like student government-ish. I was the appointed chair of the Club Finance Council, which basically gave out, student funds to clubs and organizations. So I did that. I was the president of the Third World Coalition for a couple of years, which was the coalition of all the ethnic student organizations on campus. And so, as part of that, you had the Asian Pacific Islanders and the Filipinos and different Latino clubs, the African American, Native American. So I was kind of the president of the Third World Coalition, and in that space, we organized demonstrations. So when I was there, it was during the time of the Bakke, the Bakke decision and the Bakke issue, which was a court case that surrounded the ability of universities to employ affirmative action to achieve certain goals. And so it was a pretty raucous time on campus around what was called the Bakke decision. But so I used to help organize, meetings with campus administrators about particular issues that maybe the ethnic minority students on campus would face. A time, would help organize demonstrations. We also endorsed candidates for student government and things like that. And so I would lead interviews of persons that were seeking positions, either wanted to be endorsed either for like student body president or vice president or student body council, things like that. So I was active on the club side through the Club Finance Council, and then I was also a peer advisor counselor. I did other things. I was a resident advisor for 2 years in the dormitories. So I was very active. On campus and student clubs as well as in the residence halls.
I can see how your major shift or could shift based on where your interest for the student governments went.
I was a very busy boy at UC Davis, and when I started at Davis, I mean, you know, um, it was quite a culture shock going from a almost completely ethnic neighborhood and almost completely ethnic high school to UC Davis, which at the time was still kind of growing out of its UC Berkeley Ag Campus affiliation, and there were maybe like 13 or 14,000 students when I started. Most of the ethnic minority students lived on just a couple of the dorm floors, mostly because it was a more mutually supportive environment than maybe just being on other dorms that, where people they just weren't used to living in that kind of environment. But by the time I graduated, it was 23,000. And of course, now it's more like 40,000. So it really just grew tremendously during the time, became much larger campus, much more multi-ethnic. The number of courses and majors really expanded. When I was there, you couldn't even minor in anything. You couldn't cross college major. You pretty much were I was in the College of Agricultural and Environmental Sciences, and then moved to Letters and Sciences. You pretty much were in the college that you were in, and that's the kind of way you stayed. It's just so much. Younger persons these days have so much more opportunity. They could, major across college. They could also minor. They could double major. So when I was in school, I'm older. When I was in school, the Vietnam War limits on units was still in place. And they didn't want students to stay at the UC 5-6 years to keep out of the war. So they put a unit cap on people. And that unit cap, I started in 76. The Vietnam War unit cap was still on in 76. So if you could graduate at 180, if you wanted to go over 196, which is less than a year, like into a fifth year or something, you had to petition, and they were pretty rigorous. So again, it was a very different time. They wanted you in and out in 4 years, 4.5 years, because people were still staying in like when I was a freshman, the juniors and seniors were still affected and still subject to the draft and things like that. So it's just a different time.
Yeah, I wasn't even thinking about the impact of the Vietnam War on your college days.
Oh yeah, when I was a freshman, one day I went on the main quad. Everybody was wearing black and had black flags, and I was like, "What is this?" And it turned out it was the anniversary of the Kent State student massacre. And so the juniors and seniors were there during that time, during when those students were killed on that campus. And so that was really, that was a very, very piercing issue for them. And so when I was there, people were still, there still was an annual, they call it Whole Earth Festival. It was still the hippie times. And we knew that when the Whole Earth Festival happened, that 3 or 4 months later, there'd be lots of marijuana plants on the quad, because people would, people would plant them and just to mess up the university's quad and all this kind of stuff. It was just, again, it was the echoes of the Vietnam War when I started. Even when I was in high school, I remember sitting down with my mom, listening to them do the lottery for the draft. I was still in high school. The draft was still active when I was in high school. And I was sitting down. I think my birthday, which is in November, ended up being pulled 180th or 200th. So I didn't think they'd ever get to me in the draft. But again, it was a different time. Lots of echoes of the Vietnam War when I was in college still.
Yeah, for sure. How did that influence you after you graduated?
I'd say my dad being in the Army influenced me more. He, the U.S. occupation forces in Japan wasn't that horrible for our American GIs, but his experience in the Korean War was really tough. It was never really a declared war. It was always the Korean conflict. The weather, the snow, and the marches in the snow, and the kind of the back and forth. If you know the history of the Korean War, the back and forth of the fighting up and down the peninsula was pretty brutal. And he would never, and Martin knows this too, he would never talk about, when you're a kid, you ask your parents sometimes pretty stupid questions like, did you kill somebody? It's innocent to you because you don't really know, you have no reference for it, no context for it. You grew up watching the store. You end up watching programs like Combat, or there's lots of like shows on about war and things like that. And sometimes you ask your parents stupid questions, and so. But my dad would never really talk about his war experience. We just found out later, either through pictures or talking about him. It was a pretty brutal experience. So I just always, had a pretty good understanding, at least particularly even from a young age, about how brutal war could be, just from what we were able to glean from my dad, and just kind of doing more of my own history and research of the Korean conflict.
You talked a lot about your dad, in this case around his military experience. Prior to that, his work as a shop steward and working in a plant. What was the best piece of advice you ever received from him?
Boy, I guess, he had a very, very strong work ethic, and he always believed you work until the work gets done. Martin used to hear this too. Even though he would work, he'd always take overtime shifts or whatever, because you get, time and a half, or, double pay or things like that. He also, to help put us through Catholic school, went through Catholic grammar school and Catholic high school, and even though we lived 6 houses or 8 houses away from the high school that he went to, which was a public school right down the street. But he always wanted us to have a better education. And so he was always about, you work until the work gets done. He would come home from work and then go work at bingo or some other thing at the school to help put us through school. And so I think the thing I took away maybe was, maybe most, it wasn't necessarily a word or phrase. It's just mostly, I think it's just his work ethic. And so we've all kind of, the whole family operates the same way. My dad was a pretty tireless worker. My mom was too. And so I think all of us have kind of, fallen into the same footsteps, or have that pretty much that same philosophy.
So I imagine that's really shaped how you approach your professional life of going in with both feet and dedicated to the work that you're doing.
Yep.
How do you get from leaving college to where you are today?
Yeah. So again, I graduated from UCLA. I got an MBA I graduated from Davis undergrad in sociology. I went to UCLA to get a master's, mostly because by that time, in the very early 80s, the kind of the 60s revolution and activism was kind of moving into the Reagan years. And so I kind of wanted to see, I could have gone to be a social worker or something like that, but I wanted to kind of see how the business side of things worked as well, and see if there's a way to combine, kind of my interest in more either political activism or social services could be married some way with some kind of business acumen. And so I went to UCLA. I got my MBA down there, and when I was there, I interviewed with the Legislative Analyst's Office, which does nonpartisan fiscal or budget analysis for the legislature. And so for me, it was working in government, but applying kind of, the potential to apply some business acumen, or, how to make things work effectively and efficiently, but in government. And then when I got that job in the Legislative Analyst's Office, but because I was interested in kind of more social programs, I immediately was assigned to work on the Medi-Cal program. So it was a good fit for me because it was still a socially oriented program I was analyzing on behalf of the legislature, but making recommendations to make the program effective and efficient, for taxpayers. So for me, it was a good mix of my interest in social programs, but applying kind of my educational background to it, if that makes sense.
So Medi-Cal's going to come up in our conversation a little bit later as we're starting to geek out on the policy side. For those that aren't familiar with Medi-Cal, how would you describe what it is?
Yeah, so Medi-Cal is a federal program that's known as Medicaid. We call it Medi-Cal because California likes to have its own names for everything. It's basically a program where lower income individuals who don't otherwise have coverage can gain enroll in a set of comprehensive benefits, everything from doctor visits all the way to long-term care. So again, it's California's largest social services program. It enrolls about 14 million people. So it's good 35% of the population, if not more, receive their health benefits through Medi-Cal, and the federal government picks up about 50% of the cost. So it's a federal program, but there is a state share, and so the state picks up about 50% or so.
Is it fair to say that throughout your professional career, Medi-Cal has been part of it?
That Medi-Cal has been a big part of it,
right? For the policy side of the work that
it has. Yeah, I've always starting at the legislative analyst office, working in different offices in the legislature, always on the health side. Same thing in the governor's offices, always on the health side. It's always been a big part of it's the largest state program that exists, even bigger than education. But it's always been a kind of a central theme of the work I've done. For a while, during the Newsom administration, I was even its director. I was director of healthcare services for 5 months while I was doing the other job too. So it's always been part of what I've been interested in. I've always been very interested in healthcare and health coverage. And so whatever job I've had, health coverage generally, but Medi-Cal being the biggest piece of that, has always been a piece of what I've done.
Your career has bounced in a lot of different types of offices, some nonpartisan, some very partisan. What was a jump like from going from LAO, Legislative Analyst Office, which is a nonpartisan office, to something that became partisan, both within a legislative context and then working for?
Yeah, that's a good question. So I moved from the Legislative Analyst Office to the Senate Budget Committee, and there you're working for the state Senate, but in more particular, whoever's in charge of the state Senate, which at that time was Democrats and still is. And so one of the reasons I did that is because when you're in the Legislative Analyst Office, you're making recommendations that are partisan blind. It's just, they say they need this much money to do something. You're disagreeing based on they did the wrong estimate, or you think it could be done more efficiently or more effectively, or why don't you do it this way, or here's your options, legislature. But a lot of times the legislature, at least during that time, I would go and make a presentation before a budget subcommittee, but there are people sitting next to them that were staff that I could tell they're talking about what I was talking about and making a suggestion about whether they should go along with what I was suggesting, or were helping craft an agenda for them. And so I wanted to be kind of sitting up there for a while to see kind of how that was different from me just talking to them and not understanding why they'd make the decision the way they'd make them. I could guess why they're making the decision away, maybe politics, or it affected someone's legislative district a certain way. I mean, I would never know, but that was a little bit frustrating about that position. And so I wanted to go sit up next to them and be a legislative staffer versus just kind of making a nonpartisan argument in front of them or discussion in front of them. I wanted to be they're more on the decision making side and help advise the legislators on decisions. So it seemed a logical thing to move from making the presentation to, if I could, be part of the more part of the decision making process. So that's why I made the jump.
And then going from there into working for some governors, then nonprofit, and now currently working for a governor. What's that experience like, bouncing in and out of those highly political spaces?
I mean,
big politics.
Yeah, I mean, I've always been blessed. I've always had something interesting I wanted to do after the job I had before, and always had either the kind of history or had worked with others in those different administrations where we knew each other and thought I could, do a good job for them. Again, I've always been about trying to get very coverage for everybody. And so my through line, to your point earlier, Paul, whether it be Medi-Cal or now it's called Cover California or its predecessors, has been about getting coverage to everybody. And so I've always participated in different kinds of jobs or roles, where I thought I could contribute toward getting everybody coverage. And so whether it had been, even during the Governor Pete Wilson time, and then Governor Gray Davis and Governor Schwarzenegger. I didn't work for Governor Brown, part two. Then back with Governor Newsom. It's my through line's always been Medi-Cal coverage, healthcare, trying to get folks covered that weren't covered, because I believe that healthcare is a fundamental right, and so but so many people haven't had it, so many millions over the years, and we've been chipping away, and come 2014 we'll have chipped away even more, picking off another group of folks that don't have access to preventive services or comprehensive preventive services. So it's always been with the goal in mind, not just working for someone to work for them, but working for someone with a particular purpose or end goal in mind, from my perspective. I mean, I can't speak to, the persons that would hire me about, they obviously hired me because they want me to do, a pretty broad-based job and, put in my hours for them and give them good advice and things like that. That's fine. But I always had a goal going into those jobs. I always had a particular purpose or a particular, end goal in mind when I worked for them.
I mean, that's a huge goal to have, right? To get everyone covered. What shaped you to come to that conclusion?
Well, I mean, where I grew up, a lot of people didn't have health care. And even looking at my parents, and my parents were lucky that we had private insurance, through, the steel workers had pretty good insurance at the time. And so, we always had some place to go. But very early on, my parents believed in also the clinic movement. And they used to bring us to the community clinic where we lived in Fruitvale, which is a community-based, with the community board kind of thing. It used to be a free clinic, moved into a larger, what they call federally qualified health center. And so I always noticed that people are going there for free care. They didn't have coverage. And a lot of times would come in pretty bad shape. And so that always made an impression on me. Even kind of growing up. And so, as you grow up and you kind of like learn more and talk to more people, you realize that not everybody grew up with insurance. A lot of people don't have insurance. They even were going to college without insurance. And then the kind of things that they had to do, where I would just say, I go see the doctor. They'd say, well, I haven't seen the doctor in 5 years, or I've never seen a dentist, or, I can't do this, or I can't do that, or, I have to go to Mexico to get care, or I have to go to Canada to buy prescription drugs or whatever. So again, you're once you kind of get out there and talk to other people, you realize that it really is a big, huge issue. And when I saw just in my little community, obviously grew to a larger public policy awareness on myself about, how I could help. And so wherever I've been, we've always chipped away, whether it was a situation where you're trying to cover a new group of people, or just make it easier to get in, reduce the barriers to get into coverage, reduce the barriers so that people can stay in coverage versus getting, kicked out. Looking for new ways, if a particular governor would be like, I don't really want to expand Medi-Cal. Well, can we put some state dollars in to match with a person's dollars? Is there some kind of matching thing using the private sector we can do? So I always just I tell people I'm in it for the species. I want to get. So come January 1st, 2014, it looks like we'll pick off the last group of individuals. In this case, it's undocumented adults that don't have access to a comprehensive set of benefits if they're low income. And California, would be the first state to do that. But there's all kinds of issues either over the years we've had to encounter, either because the federal government didn't want to pay for them, or they're undocumented, or there's barriers put up here, or barriers put up here either to entrance or retaining people. And so it's all been about over these years trying to give people access to a comprehensive set of benefits. And once you and hopefully reduce the barriers, so once they get in, they're able to stay in and not lose it again. So.
No, I mean, that's really helpful.
I know that was a lot. I get that was a lot, but
No, I mean, it's all helping create understanding. And Martine and I want to geek out a little bit and talk about this idea of health policy and what it looks like,
Sure.
and get your perspective on it. But before diving into that space, when you're looking about those examples around, how you saw others getting care and the FQHC and their relationship with FQHCs and other types of insurance, et cetera. Is there one story that stands out that just keeps you motivated on really pushing forward towards this goal of getting everyone covered?
I mean, I think you know, in I don't know if there's one. I think, there. I used to be the director of eligibility and enrollment for what's called the Managed Risk Medical Insurance Board, which is a predecessor. It was a program called Healthy Families, which is now part of Medi-Cal. And taking those phone calls from families who were just desperate for healthcare and had all these horrible stories and things of their interaction with the healthcare delivery system, or have to go in the emergency room. In my various roles in government, you get to meet a lot of people, right? People want to meet you. They want to bring in groups to meet you. They want people to relate their personal experiences to hopefully have the kind of impact that will assist them in achieving their policy goals. They hope you will listen to them and will agree with them. So I've just heard literally thousands of stories over the years. So I'm not sure there's any one, sometimes just want to make you cry, can drive you to tears just because of the experiences that people have had. And it's really, a lot of it was really about, the early days of even getting coverage for their kids, particularly if they're undocumented, and the parents struggle, with their children and relating to their children. They don't even care about themselves. They weren't even worried about themselves. They're really about their kids and their teenagers and things like that. So it's no surprise that when the legislature decided to expand coverage, it was first to children, even above the Medi-Cal level, and then undocumented children, because because parents always kind of want to start there with their kids, even and start thinking about their kids before they think about themselves. So it's not really there's no one story. It's just more like hundreds and thousands of stories.
Well, Rick, I'm going to go ahead and segue off Paul's questions. Him and I are, like you said, we're going to geek out and ask you some more specific questions because
Okay.
How would you compare the quality of public medical services versus private, and then how do you deal with those discrepancies?
So things evolved over time. Back in the old days, you used to have charity hospitals and things like that, which are like the place where people had to go and had lots of different reputations and things like that. That moved into like public hospitals, public clinics. Only some counties had them, some didn't. But starting in the 80s, we started having managed care plans, which are much more organized groups, organizations that had specific contracts with providers to provide specific types of services, and where you actually had like a primary care physician. So Medi-Cal, which was kind of earlier just kind of fee for service, some people participated, some people didn't, move much into the more organized space. And even for-profit companies, for-profit insurers plus private or not-for-profit insurers. So a lot of the kind of networks and names you would see in the private sector, you started seeing in the public sector. Kaiser, Blue Cross, Blue Shield. There are lots of iterations over the years of different names and conglomerations and names, but it's evolved over time. And just like the Medi-Cal population has increased, it's almost like a population you can't ignore. If you're 35, 40% of a population or more is in Medicare or Medicaid, and the public sector is paying for half of the expenditures in the country, a lot of the traditional insurers that may have been only private insurance or employer-based are now in the public space as well. I think that over time, expectations have obviously increased, or requirements for measuring data, measuring quality of care, those things that may have existed more in the private sector are now in the public sector as well. Our state Medi-Cal program just re-procured its private commercial contracts. They were announced last week, and they're pretty rigorous in terms of the types of services and expectations on those health insurers. Healthcare itself has also changed tremendously. It used to be, used to count, how many doctor visits, a person had and how many vaccinations they have. As things have evolved, particularly on the public side, it's also now about what kind of linkages you have to homeless service providers and what kind of linkage you have to help people that are having food insufficiency, and just a much broader range of links to supportive services that were never traditionally part of healthcare. It's not like just going to a doctor and counting a widget. It's also about what they're doing when they're there, the kind of screenings they're going to get, and the kind of linkages you make to other services that can help support them in their life. Because as we've learned, your healthcare is as much about, or even less about, your genetics and more about the other things that impact you where you live. It could be the situation you're facing in your household. It could be your housing. It could be your food. It could be your diet. It could be lots of things, what they call the social determinants of health. And, whether we like it or not, we're finding out that your longevity in life is less about your genetic code and much more about your zip code. So if you look at, in a city, you might have 2, 3, 5, 8-year difference in lifespan and longevity in the city based on the zip code, because of all the other things that are pushing down on individuals in areas where they live, than in other areas where they live. So the healthcare delivery system is evolving along with our understanding about how what they call epigenetics work, about how the different impacts that affect us as human beings in larger society impact us. So as we're having more learnings about what affects our health, our overall health and wellness, the healthcare delivery system is reflecting those new learnings in terms of the way they're brought into the clinician's office and the kind of things that are now expected of them. Much like the schools used to be reading, writing, and arithmetic. That over time they've evolved into having other services there, including health services and linkages, supportive services, and now what's called community schools and things like that. So, as we have learned about what is the best way, if you have a person in your office, what's the best way to impact them in their overall health? Same thing with school. Kids are there all day. What's the best way to impact them in their overall health, versus just seeing them for what they came there for? I have a sore throat. Well, we want them to do a lot more now than just see your sore throat. You've gone there to learn about, to take, learning English, and you want to make sure they learn their English and math and things like that. But while they're there, you are able to impact their broader health by, asking certain questions or having other services available for them as well.
So what do you do to assure that there is kind of a parity between them, between the private and the public sector, or can you?
That's a good question. Parity. We are constantly working toward. Not everybody in the private sector has what they need either, and so our overall goals are to make sure that people have as ready access in terms of the kind of benefits and the services they have with private insurance. Medi-Cal is even broader than private insurance. It covers long-term care. When the private insurance I have and the private insurance you have doesn't cover long-term care. You have to buy that as separate insurance. It's not part of what that one card will give you access to. So there's always going to be some differences. There could be situations where a Medi-Cal plan has not reached an agreement with a particular set of providers or a particular hospital, but they still have to have a robust network. So they'll have a different hospital and a different set of providers. And so, we also have to make sure that the services we get are culturally competent. So we have a set of cultural competency, policies and rules that even the private sector doesn't have, to try to make sure that people have access to the services they need in their language. And if they can't, to refer them to somebody that does or provide them language services. Those are things that don't even exist necessarily in the private sector that exist in the public sector, because we do have lots of unique things. The sickest children in society that have lots of genetic complications and all kinds of other kinds of things come to the state. And so they're kind of we have a different kind of network for them that is most like children's hospitals, lots of specialists. So it kind of depends on where you are accessing, the kind of services you're accessing in the system. But obviously, the major goal, and whether it's private sector or public sector, is to provide the correct services in the correct place at the correct time, or the right services in the right place at the right time. And that's an overall societal goal, whether you're in the private sector or the public sector. We have lots of, the state does scorecards on private insurers, and Medi-Cal does its own scorecards just for Medi-Cal. And we try to make sure that if things are different in one system or the other, that we're pushing the plans to get to that. What are you doing in the private sector or for private that you're not doing in Medi-Cal? We want to know about that, because why is there a 85% immunization rate? And this, I'm just making this up. This is not a real thing, but why would the immunization rate be higher here than here? Or why is it higher? Why in the same community is health plan A doing better than health plan B? So it's really not even always about even the systems. It's about one insurer versus the other, or private sector versus public sector. So it's even health plans themselves. Health insurers are doing different things to get people in and keep them in, or motivate them, or whatever they're doing to keep people's diabetes in control under health plan A might be a lot better than health plan B. So it's also about best practices and learning from each other, so that our whole system rises at the same time.
What I love about it, how you operate and think through these challenges is you can realize the complexities behind it, and there's not necessarily direct trade-offs, right? It's not yes or no type of responses. It's all this gray area that comes in between. You talked about a little bit about the social determinants of health. That's a highly technical type of term, but gets into where you live and types of things you have access to. I'm realizing there's some paradoxes that are starting to emerge, including a paradox perhaps that is between health and wealth. And I know that you're doing some cool things when you're thinking about generational wealth and how that ties to healthcare systems. How do you think about all those things tying in together?
Yeah, that is income and lack thereof is one of the social determinants of health. So income inequality, housing inequality, food insufficiency. And so, we have to continue to strive to do what we can on that part to raise up. Again, it is more about your zip code than your genetic code. And you have higher income zip codes that have a longer lifespan than lower income zip codes, and trying to figure out, what can we do on that side. And so people are trying to things like, guaranteed basic income, for example. People are trying to make sure that we're doing a better job of making sure people know what, whether it's on the food bank side or CalFresh, which we used to call food stamps, that people know what's available to them. We are doing ACEs screening, which stands for Adverse Childhood Experiences. We're now doing ACEs screening in the Medi-Cal program in pediatricians' offices now for adults, and now we're also requiring it in private insurance as well, because we know from experience the higher an ACEs score is, the more adverse childhood experiences a child has had, the less likely it is they're going to be on a very good health trajectory their life. So you have people that are maybe 35 on the outside, but 55 on the inside because of all the pressures and stresses they've had, even as a young child. It has affected them physiologically. And again, I'm not going to get into studies about, I'll just throw out the word cortisol, which is something that is produced in your body. But if you're subject to lots of stresses in your life as a young child, it continues, the cortisol production, which usually manifests itself during periods of high stress, never turns off. And just keeps producing and producing and producing, and starts wearing down the insides of your body over time. And so just things like that, there are stress. We're learning about, the physiological impacts of the environment you grew up in and its long-term effects on your physiology and then your lifespan. So learning about ACEs, learning about the social determinants of health are helping us try to design programs and pathways for people to reduce their stresses. We're putting billions of dollars into child behavioral health. So if we can catch it early, if we can identify it through ACEs and other screening early, it has such a huge emotional or socio-emotional positive impact on your ability to succeed in school. We know if you succeed in school, you're going to have a much better, time of either going to college or expanding your job opportunities. So again, we're now looking at a very young age on those, what we can do on the health side to positively impact the longer term trajectory of a person's life, as well as trying to figure out what we can do on the social inequality scale to tide raises all boats, right? And so we have to look at the things we can do on the social inequality scale to impact communities to give them a better shot.
I've got a question for you. We're gonna keep going down this healthcare road here. Rick, how did COVID-19 affect the delivery of medical services, and do you think that those changes are going to affect future programs and how you approach providing medical care in the community?
So overall, the life expectancy in the United States has gone down the last couple of years because of COVID. We've declined like a year or two in life expectancy. Most of the rest of the world, even with COVID, didn't happen. Happened here, and even more dramatically among communities of color, African American, Latino, primarily. What COVID did is amplify lots of the long-seated things we kind of always knew about, but that resulted in like really negative health outcomes. And so, if all of a sudden you couldn't go to the doctor because things were closed, you'd have more people that were suffering from diabetes and hypertension and mental illness and things like that. If you already had these underlying health disparities, which exist more in some communities than others, COVID was more likely to put you in the hospital, more likely to kill you. So that's one of the reasons why, we already had these underlying health disparities for a whole variety of reasons, a whole variety of societal reasons, and lack of access to health coverage and things like that. When COVID came, it then disproportionately impacted those same communities because they had underlying health conditions. Also, for reasons that, people couldn't afford to take off work even when they were sick, for example, because they couldn't afford it. So they go to work sick, they got sicker and ended up in the hospital and some dying, or just, more and more people had COVID because they couldn't be 6 feet away. They were working in jobs that didn't allow for social distancing. And when they did get sick, they still went to work and infected others. I mean, there's lots of, and when they got home, it couldn't be like they're in a separate room somewhere. They had to take care of kids, or they were taking care of grandkids. I mean, there's lots of issues around how COVID spread and how debilitating and devastating it was in certain communities for a whole lot of reasons. And so again, you did see our overall U.S. How long we were living, our longevity rates have gone down. We'll see what that looks like, over the longer term. It went down for 2 years in a row. How it impacted health coverage, and what we will see the most over the long term is that in California, at least in the public sector, we've been very reluctant. We had been pretty reluctant adopters of telehealth and other virtual technologies. And what it forced us is to go cold turkey right away into almost 100% telehealth. The whole country had to do it, private sector and public sector, and develop new ways of thinking about, okay, how are we going to pay for this, and what do we pay for, and how do we do not only just how we pay for physician patient interactions, but how do we pay for physician specialty interaction? We teleconsulting and things like that, and now we 24-hour hotlines for people that call in and have to worry about languages. And so one of the biggest takeaways is the very rapid adoption, and now permanent adoption in Medi-Cal and the private sector around telehealth and the opportunities for now we know, for example, it's not a panacea. You still need to be able to go in, and we will still require people to have a primary care physician. And if you want to establish in Medi-Cal, for example, if you want to establish a new patient with your clinic, you still got to see them mano a mano. You still have to touch them. You still have to lay their hands on them and see them, eyeball to eyeball, because you want to establish some kind of patient relation. And some things you can't describe. You can't, you have to feel and touch the person to see if something's wrong. So, but at the same time, we're adopting lots more modalities around telehealth and making that kind of a permanent part of the system. And it turned out for a lot of people, they got used to it. That was a much better way. They could reach someone in language and right away, much quicker than having to wait longer and have to wait for a translate. I mean, it's just different than it was before. I think we also had to relearn how to do like mass public health events, mass vaccination clinics, trying to figure out how to communicate with people and reduce their fears to come in for a certain visit or come and get a vaccine or come and do this or come and do. So we had to like relearn some of our traditional public health activities that we hadn't had to do since the polio vaccine with Jonas Salk. And I think Martin, you were too old by then, but when I was a kid, and I'm older than you too, I think, Paul, but when I was a kid, we used to line up for sugar cubes, and it wasn't even no one questioned it. It wasn't like now you have lots of vaccine hesitant, vaccine skeptic people. I mean, polio was a really devastating disease, and God forbid, now we're seeing it back on the East Coast again a little bit, and that's just a horrible, debilitating disease, very, very contagious. Everybody lined up their kids, and you went for like 3 times, and you got the polio vaccine in a sugar cube, and you took the sugar cube, to help the kids. People are scared of shots, but they put in a sugar cube, you get a sugar cube. We had to learn how to do those kinds of things again, which we hadn't had to do since the late 50s, early 60s. And of course, my grandparents and would talk about the Spanish flu, which is 1919, because their parents would talk to them about. They may have been very little or maybe not even alive, but their parents would tell them. And so that got passed on to at least my generation. That generation is now gone, and so the Spanish flu is a distant memory for very, very few people in the United States right now. But I remember from my grandparents talking about. So again, I think the biggest change is really around telehealth, and we had to learn and even do grants and things like to bring the health community up to speed. For a couple of years, we were waiving the state laws around the inadvertent release of medical information because people were doing Zoom. They didn't even have things that were like super protective people's medical information, because everybody's having to do Zoom, and someone walks behind you when you're doing Zoom and someone's talking to you, you're going to hear that's an inadvertent release of medical information. And so we had to waive a bunch of the rules because people were in these environments they weren't really used to or next to each other or didn't have ways to make their conversations more private or even transmit medical information very easily through electronic means. So we've had to adapt a bunch, and things have gotten a lot better. But that will be a permanent fixture, I would say now, of our medical system is telehealth and telecommunications. And we had to speed up our medical record transmission capabilities. But what also has come out of it is the need for better data transmission. When Imperial County, which was the bellwether, right? That's a place where hospitalizations really kicked up. Heavily Latino, people really couldn't be socially distanced, lots of underlying medical conditions. That was the bellwether. We were learning from that. The hospitals there were overwhelmed. We were transporting people, and we were trying to stay. It was like the New York situation, right? We're like, oh my goodness. We were having to transport people from Imperial County into San Diego and further places north. We learned very quickly the medical records weren't going with them because the hospitals in Imperial County couldn't talk to the hospital in Imperial County, we were transporting people up in the north. So from that whole effort came a new health data exchange effort, which coming within the next 1 or 2 years, all the big entities are going to have to be able to transmit data to each other using a standardized format where we talk. Again, that is going to be a permanent part of our ongoing health infrastructure now. But we learned from how we could communicate and not communicate, both in terms of data and just the interaction between provider and patient. So those are 2 things I think we really learned a lot about, as well as reminding us, hey, these health disparities are here. And when you have a pandemic come along, it really, and health inequities, health disparities are really amplified by the pandemic. And hopefully we learned a lot more about how to more quickly get vaccine and information and dollars to communities than we did before, as a result of all of this. But again, we don't know what's coming next, but we certainly have had some takeaways from this past. And again, we're not even out of it. So we haven't even learned all we're going to learn. And as you know, Paul will probably be teaching this in 3 years. What did we learn from the pandemic? Or pandemic and public policy? Or I don't know what books Paul or others are going to write or get involved with. But again, books and seminars and papers and movies and everything else is going to come out of all this.
Well, let me ask you a couple other final questions, because I don't want to. There's a million questions that I know Paul's got a bunch of questions as well. So,
and unfortunately, I do go on. So I apologize.
No, I actually find the conversation very, fascinating and very, very informative.
Paul, to your earlier point, there was no lack of conversation in the Figueroa household. And when we get together, if people don't know us, it's like, well, Martin, be prepared.
Yeah.
Everybody likes to talk, and because of 9 kids, you end up over time the tones keep getting higher and higher because people are trying to talk over each other, we're still very much, when we get together, still very much like that. It's a very rambunctious crew.
So
that's a good skill to have in the governor's office.
So let me ask you this, Rick. In terms of, people always have questions around. I have a couple questions. I don't know if you want to write this down here. For the part one would be.
Oh my gosh!
I know. Part one would be, if you can explain in some ways the high cost of prescription medication and why they continue to be high, like some of the trends that you think. I think you've spoken about this in the past with me, and then the other part of that, like how do you handle that as a state, right? And
sure.
I know that. And then
the answer is very easy. They're high because we allow them to be high.
Well, and I want you,
because we allow them to be high.
Right, and I want you to speak about, like, touch on that a little bit. And then the second part of that is, there's caps on HMOs, PPOs. They have caps if you have serious illnesses, right? Especially as you get older.
Right.
When those caps run out, I know that there's other funding sources that kick in. And then when those funding sources run out for like an HMO or even Medicare, Medi-Cal, and I know we use those terms interchangeably during the podcast. Does the state go after someone's personal assets to pay for that? And I know that you and I have had this discussion in the past. Yeah. There's some real changes in the next couple of years that are very, very critical. I think are really important to bring up during the podcast.
Yeah, so we on the prescription drugs, I mean, they're high because we allow them to be high. There's an imbalance in market power between pharmaceutical companies and purchasers. Insurers, large employers, and government are all frustrated about it. It wasn't until this most recent federal legislation that Medicare could even negotiate prices, and they're the largest payer in the country. So we've allowed this to occur when other countries have not allowed it to occur. Now, it's also true we have lots of medical innovation, lots of pharmaceutical innovation here, but so do other countries, and they still don't pay as much as we do. And certainly the cost of that research and development is amortized in the price of every pill that you take. So it's not the actual ingredient cost. You're also paying for marketing and R&D and investments and profits and things like that. So, but again, we don't drive and haven't been able to drive as hard a bargain as we probably could. And even in the generic market, a lot of the generic market is high. So again, the federal government is finally, going to be negotiating for Medicare stuff, and hopefully, but again, what's hard about it is you're negotiating over how much you pay when a lot of the problems are in the initial setting of the price, right? So insulin's a good example. Might be 300 a vial when maybe it's actually the cost is 30. And so it's just a market failure, and no one has kind of stepped into that market and tried to take on the current complex and very complicated interactions between the manufacturers, wholesalers, distributors. It's a very complicated system that we have here of getting a pill from the manufacturing plant into someone's body. So the governor, for example, the legislature and the governor agreed that we're going to put $100 million into insulin this year and put something on the street that says, hey, we'll contribute up to $50 million to help develop 3 generic insulins that we can sell at cost. So it wouldn't be the whole system right now where we have a price of, $300 and then we have rebates and there's this and this and this and this. We're trying to break the wheel, get to the underlying cost and sell it at that cost versus the current system we have of really jacked up prices with rebates and, assistance programs and this and that and this and that. So that's just an example. And so there are new market entrants that are coming into this space that are trying to sell things that cost and break the wheel because the current system we have is just so darn expensive. And again, we've allowed it through the way our patent system and the way that we allow extensions of patents, and people have abused the patent system and various things. But again, we are learning the hard way and trying to pick up on what other countries have done, as well as the state is trying as a social good, trying to spend some of its own money to kind of help break the wheel a little bit, at least on insulin, if not others. Who knows what's going to come down the road, and make a social investment so that we can bring the cost down, not just for the state, but for everybody, for uninsured people, for the private sector. I mean, we don't care who would buy it. We want to make it available cheaper for everybody because it's something that's necessary to keep people alive, and it's costing way too much. So that's kind of one piece of how this, how we're trying to make some changes. Obamacare, and we hear less and less about, Obamacare is a horrible thing these days than you used to. But Obamacare, or Affordable Care Act, got rid of annual maximums and lifetime maximums for coverage. It doesn't mean you still don't have co-pays and deductibles and things like that. But they did get rid of annual maximums and lifetime maximums. It doesn't mean that now people have, still go bankrupt because of medical costs, because of deductibles and co-payments and co-insurance. So it doesn't mean that people still don't have. There's a large component of medical costs that lead into bankruptcies in this country. But that there is a cap, like you have said on there. Now, there was people, insurers, others were moving around it by doing things like what they call surprise billing, out of network. A lot of things don't apply to out of network benefits. And so the state and federal have had to step in where there are these, where issues have arisen about people still going bankrupt because of medical circumstances, by stepping in for they call the No Surprises Act, or making sure that, if you get in an auto accident and you have to go to the hospital, you don't have a choice about what hospitals you're going to if you're unconscious. You have no choice over who's seeing you. So, every hospital has to take you in for emergency care, but certain providers, if they were out of network, if they were seeing you and you were on the operating table and you were some specialist or something and were out of network, they were charging you, balance billing you beyond whatever the insurer would pay for what their actual costs are. They're called balance billing. So people are going, even though there's a cap on their annual expenditures, there's no more cap on what an insurance company had to pay, there were still no caps on out of pocket in some cases when it was out of network. So again, government has had to step in to those situations where there are these imbalances in power between patients and providers or the way that they interact with the healthcare delivery system. So we had to step in where necessary, and no doubt we will continue to step in, as if there are these major issues that happen. But again, Medi-Cal is free. For example, in your example, Martin, it's just free. There's no out of pocket, no maximum. It's just free. Medicare just recently, again, with the most recent Inflation Reduction Act or whatever its acronym is these days, put some new limitations on how much out of pocket was going to be for seniors for the first time. But again, we can change these things, and hopefully we'll see a lot less bankruptcies associated with the medical system than we've had in the past. But it's taken us a long time to get here. And unfortunately, even with copays and deductibles, they can still put people in very difficult situations, particularly for multiple people in a family, such that it leads to medical bankruptcy or all kinds of other hardships, or cutting their pills in half because they can't afford the next copay. But again, that's a lot of it's related to what's being charged for a drug, which is the actual underlying cost. And so until we get to the actual underlying cost and are making it available at closer to what the underlying cost is versus what the price is, which is jacked up for all kinds of reasons, you're still going to see people in pretty dire, in a lot of cases, pretty dire straits about the particular medicine they have to take, putting them in a very difficult financial position.
Yeah, there's so many questions that are surfacing around health policy and health economics.
Well, Martin asked a two-part question, so you got a two-part answer. So
I know. But it's really just opening the door for all these really enriching things that make the whole system work. We're going to hold off and maybe pull you back for another podcast. But want to get your insights. If you can pull out that crystal ball, what's the future of health policy?
Boy, well, I'm hoping it's a lot less about health coverage, because for a long time people were focused on getting people covered with Obamacare and continued Medicaid expansions and things like that. Hopefully it's a lot less about getting people covered and a lot more about how to drive value once they're in, and incentivize value once they're in, because once you get people in, you still have to retain them. It still has to be affordable, whether it be for government, the employer, the people buying individual coverage. So it moves from accessibility to affordability. And hopefully we've done more and more on the accessibility side over time. And now we have to continue to figure out what to do more about the affordability side of the equation, which is, in many parts driven by, kind of the healthcare inflation trajectory. So you've seen more and more states, including California just this past year. We have a new Office of Healthcare Affordability that's going to be putting in certain measurements and targets for healthcare expenditures, first overall, and then by health industry sector by 2028, I think it is. Now we're like the 6th or 7th state that is doing this. So it's over time, we're getting more and more into how the systems can incentivize value, and behavioral health and preventive care. To hopefully level, it's hard to actually drive healthcare costs down. We're all getting older. We always expect more medical technology. We want to live forever. I mean, all these things that, we have more and more, people that have diabetes and heart disease and all kinds of things. So it's not realistic to think healthcare costs are necessarily going to go on an ongoing downward trajectory, but certainly you want them to keep up with regular inflation and not outpace regular inflation, so that as long as we have an employer-based system and the kind of hodgepodge system we have right now, we can maximize the amount of people that are in care or in coverage. So you don't have people uninsured, like Martin has indicated, that go bankrupt or go without, or are going to die of premature death because they didn't have access to A or B or C. So I think over the long term, it is going to be about affordability, and to an earlier point you brought up, Paul, a better understanding and how we incorporate the things we've learned about what impact your health. It's not just the clinical delivery system, it's how all these other systems impact a person's health and wellness that then drive the costs up over time. So it's about the social determinants of health and how we develop models and delivery systems that reflect a broader understanding of healthcare and the health of a community. So it is about, it's about affordability, and those things that impact us over the long term. And again, hopefully less about, how, an uninsurance rate of 20% and how we fund that, and more about, once you're in, how we take care of you when you're in, how we recognize what's affecting you, and how we affect the long-term trajectory of the system.
The Hyper Guy motivational podcast is all about celebrating really cool people doing really cool things. Richard, I want to ask a couple of rapid fire questions at you. Are you ready?
Oh boy. Okay.
One word responses are shorter. Here we go. What book is on your nightstand right now?
The report of voter registration for June of 2022. I just got it today. I can't wait. I'm kind of a data nerd on the voter reg thing and how it impacts different districts and things like that. And so I picked that up today, and that's what I'm gonna be looking at this evening. It's not what you'd expect, but that's what I have here.
That's what you have. If you're a baseball player, what would be your walk-up song?
Oh my God. Titanium. I don't know.
Favorite place to visit?
I'd say Disneyland, because you can just get away from everything.
Most unusual talent?
Oh boy. I don't know. I don't know that I have an unusual talent. I don't know. Mark, I don't know that I have an unusual talent. I wish I thought. I mean, I remember lots of my grammar school and high school kids' friends' phone numbers. I have a pretty good memory, but that's not that unusual.
I think that's very unusual this day and age. Best piece of advice that you've received that's worth sharing?
I would say, don't make enemies unless you have to. I mean, people are kind of pretty, a lot of people are kind of nasty to each other in different forms. And I think just, treating people as human beings and not just, solely based on the politics they bring to the table is always something that has served me well. So again, you agree it's business, it's not personal. It's just business.
Richard, I filled up a legal pad with notes. Appreciate you spending part of your time with us, part of your day with us. Thanks for doing all the work that you're doing and keeping us all nice and safe and healthy.
It's never a dull moment in state government, I'll tell you. No dull moments. No dull moments. I gotta say, go Bruins too. Sorry, you Trojan people. I gotta say, go Bruins. I wore my powder blue for the occasion.
Thank you so much for being here, Paul and Richard. Just great to have you on. I'm so lucky to have you as friends and people I really look up to, and I appreciate both of you so much. And if you like the podcast, give it a thumbs up, and can't wait to have our next guest on. And in the meantime, keep learning and growing. And until next time.
My pleasure.